Hi, everybody. I'm Helen Cross. I'm the current president of the International League Against Epilepsy, and it gives me great pleasure to be here to moderate the e-forum on older people with epilepsy. We have three excellent speakers today. We have Taoufik Alsaadi from the UAE. We have Eugen Trinka from Austria and Arjune from Oxford. Just to say there will be an hour of talks with some discussion and then a further 30 minutes where we'll be able to address any questions you might have. And if you can put those within the question and answer, we will address those. Just to remind everybody, we're not able to respond to any questions referring to a specific case or patient. We just want to acknowledge the support that we've had for the e-forums series, with unrestricted grants from Jazz Pharmaceuticals and UCB. And we're very grateful for that. So as I've said, we need you to type your questions that you might have into the Q&A box on the screen so that we can address these at the end with discussion with all the panelists. And we will also ask you to complete a short survey at the end of the e-forum. It would be really good if you could complete that so we know how to move forward in the future. Just to highlight conflicts of interest from our panelists. So due to a few technical difficulties, we are going to start with a slightly different order to what we originally said. So the first speaker will be Professor Arjune from Oxford. He is there. He is Professor of Global Epilepsy, and he's also a member of the Commission for older people with epilepsy of the International League Against Epilepsy. And he's going to talk about pathophysiology of the epilepsies seen in the elderly. Thank you, Arjune.
Thank you very much for that kind introduction, Helen, and good afternoon from the UK to everyone. We'll just share my screen. So, as mentioned, it's a great pleasure to be with you, and I'm going to be talking on the pathophysiology of epilepsy in older adults. And we hope over the course of this webinar to really showcase why epilepsy in older populations is so important and why we should be considering this more and more in the sphere of epileptology. In terms of a broad overview, these are the topics that we're going to cover over the next 20 minutes or so. Look at some common causes of epilepsy in older people, think about strokes and why strokes cause seizures when they do, and quite a bit of time on whether seizures are more than epiphenomena in dementia. We'll then try and bring that together and look at the intersections of epilepsy, dementia, and stroke, and then consider one of the other main frontiers in the pathophysiology of older epilepsy, which I've put in quotes for a reason, as will become apparent later on. So as Helen mentioned, there have been a few technical difficulties, so we thought we'd really check the technical know-how by putting a poll up quite quickly and discuss a case. So this is a case that was seen in Oxford, a 75-year-old gentleman who had a probable generalized tonic-clonic seizure in April, and it really did seem clear-cut that that was an epileptic convulsion. Also, on going through things, though, there were episodes when waking after a nap where he felt quite disorientated and was somewhat uncertain of the location. These tended to happen on important days such as Father's Day, Christmas, Easter, major celebrations that were often associated with a reasonable amount of alcohol consumption. And the confusion could last for about 20 minutes or so when it happened. When he came to the clinic, it was actually very difficult to get the story from the individual himself, from the gentleman himself. His speech was very tautological. It was difficult to keep discussing the history of the events. And it was thanks to his daughter-in-law coming with him that we managed to obtain the history as outlined. The main thing that the gentleman himself was concerned about was he was very frustrated by his inability to drive. The neurological examination was normal. And this was the scan as illustrated here. I'll just give a moment to show that. So for people who are less familiar at looking at scans, you can see some white matter change. That's the bright bit. You can see that there. And also the hippocampi are quite shrunken, which is just here. I'm not sure if you can see the pointer, but you can see the hippocampi are shrunken and the white matter changes here. So the poll, which we'll start with, is what is the most important diagnosis here? So is it Alzheimer's disease? Is it alcohol excess? Is it epilepsy? Is it stroke? Or is it vascular disease? And we'll give 30 seconds for the poll to just run now. So if you could just answer the questions and think, what is the most important diagnosis here? Alzheimer's disease, alcohol excess, epilepsy, stroke, vascular disease. And we'll just end the poll there. And so the results were, so Alzheimer's disease was 24%, alcohol excess 14%, stroke 4%, vascular disease 23%, and epilepsy 36%. It's perhaps reassuring, and I guess that does confirm that the technology is working, that in an epilepsy seminar organized by the ILAE, that epilepsy is the most important diagnosis. But actually, all of the diagnoses are important, so there's no clear wrong answer here. It wasn't certain that he'd actually experienced a stroke, but certainly there's evidence of vascular disease, and seems to be evidence of dementia as well with the memory impairment. There was clear alcohol excess, and we did think that those events were seizures. So we're all familiar that epilepsy becomes more common as we get older. These are curves that you will also see later on in the talks showing the incidence of epilepsy and the prevalence of epilepsy increasing with age. The incidence there is demonstrated in high-income countries, Iceland, Sweden, and the United States. And in the prevalence slide, which is figure P, is from the Global Burden of Disease surveys. So epilepsy does become more common as we get older. But as we also know, epilepsy is a condition of inequity. So it doesn't affect all peoples equally. It is particularly more common in later life if you are a Black male. This was a study done in America looking at Medicare beneficiaries across all different ages. And you can see there that in 85 plus, the incidence rate of epilepsy in Black males is approaching 8%. In terms of the etiologies of epilepsy in the elderly, and again, we'll allude to this later on in the webinar, the majority of epilepsy is secondary to stroke. Around 50% of epilepsy in older people is secondary to stroke. And you can see the breakdown of the other main causes of epilepsy there. Dementia also features quite importantly. And what we're going to really look at now is why did these conditions cause seizures? So, well, what about stroke? Well, if we look at it clinically, the risk of stroke leading to a seizure, it's increased if there's a hemorrhagic stroke. It's increased if there's middle cerebral artery involvement, there's cortical involvement. The greater the initial insult from the stroke, the more likely that that will lead to seizures. More common in younger people, but also there are features such as if there's a genetic predisposition to epilepsy, family history of seizures. All of these may contribute to seizures arising after stroke. There are various scales that have been looked at to try and determine the risk of post-stroke epilepsy. One is illustrated here. In terms of background vascular risk factors, it's uncertain whether if you do have the background of hypertension, does that definitely lead to seizures following stroke? It probably led to the stroke, but certainly those would be addressed. Reperfusion therapies, so if you have a reperfusion therapy after stroke, that's thought to increase the risk of seizure, but there may be some selection bias here because a larger stroke with more cortical involvement may be more likely to have an attempt at reperfusion. One of the scales that can be used quite widely is the SELECT score, which was published by Marian Galovich and colleagues in 2021. And you can see that the higher the score is illustrated there in the top panel, the higher the score, the greater the risk of seizures, and particularly remote seizures. So these are late seizures after the stroke. You would do investigations for the stroke to look at where the stroke was. That can give you the measure of the degree of cortical involvement. You do other imaging to try and determine the cause of the stroke. An EEG can be helpful in stroke. If a severe stroke patient on intensive care unit, it can help diagnose non-convulsive status epilepticus in that condition. The role on the stroke unit, where someone is not on ITU, is much less certain. All of these things are trying to stratify the potential risk of having seizures after stroke. But as has been alluded to, seizures after stroke fall into two main categories. There's the acute symptomatic seizure, so the seizure that occurs very early after the stroke in the first 1 to 2 weeks, and the recurrence of seizures is around 33% in 10 years. This is not necessarily epilepsy. Remote seizures, seizures that occur outside of the acute window, there's a very high risk of recurrence, 72% over 10 years. So why? Because this talk was really designed looking at the pathogenesis. Why does that happen? Well, again, the pathogenesis is different between early events and later events. So with the early events, there can be cortisol excess and activation of the hypothalamic pituitary axis that can exacerbate hypoxic injury. We said a moment ago that hemorrhagic strokes are more likely to cause seizures. The hemosiderin can irritate cortex, just like bleeds from cavernomas can, for example, contribute to seizures being generated. Electrolyte imbalance within the penumbra, reperfusion injury is sometimes seen after carotid endarterectomy. In the early events, there's also ion channel dysfunction and disruption of neurotransmitters. So the balance of the neurotransmitters is disrupted with increased glutamate, decreased GABA. There can be NMDA-mediated release of nitric oxide and block of potassium channels. All of this contributing to seizure genesis in that early phase. With remote seizures, it's different. So with remote seizures, the stroke may leave a scar, so with reactive gliosis. That can lead to impaired ability to absorb potassium, decrease in GABAergic function, and impaired glutamate homeostasis. So as always with seizures, it's a difference in the balance between excitation and inhibition that can contribute to those late seizures. There can also be damage to the blood-brain barrier. We mentioned there may be a genetic predisposition, and structural changes in the brain network may also contribute to those late seizures. And if we look back at the patient that we had right at the start of the talk, we mentioned that there is evidence of T2 hyperintensities, those white changes that you can see on the scan. So there is evidence of vascular disease, but there's much more than that, because he was also exhibiting signs of dementia with that tautological speech, difficulty to concentrate. And the more you went into that, we did find that there was quite significant memory impairment with the hippocampal atrophy on scan. And what I would propose is that there is actually very close intersection between epilepsy and vascular risk factors and stroke, but also with Alzheimer's disease. And that's illustrated on the slide here. We can look at that in a bit more detail. So this panel you saw before, the incidence of epilepsy in the United States, Sweden, and Iceland, showing that everything increases as we get older. So the incidence of epilepsy is higher. If you have Alzheimer's disease and you're elderly, then the risk of seizures is higher still, approximately a 3-fold increase in risk if you're, for example, 8 years old and have Alzheimer's, compared to you being 80 years old and not having dementia. But if you're 50 and you have Alzheimer's disease, which is often a familial early onset Alzheimer's disease, then your risk of seizures is nearly 90 times that in the general population of that age. Now, we know that around the age of 50, the risk of seizures is not necessarily that high, but there's a 90-fold increase if you have dementia. So why does this happen? So what I'm going to try and convince you of in the next few slides is that this is not an epiphenomenon. For many, many years, it was thought that Alzheimer's disease would certainly lead to seizures, particularly in the later stages of the condition, because you're getting neuronal loss, there's disruption of the neuronal network, and that would lead to seizures. But I would argue that there's much more to it than that. If you have the ApoE4 mutation, that associates with subclinical epileptiform activity. If you do extended monitoring in people with dementia, you detect subclinical epileptiform activity using EEG. That's also been shown using intracranial foramen ovale recording in people with Alzheimer's disease. It was a small number of participants, only 2 participants, but it showed that very clearly. Amnestic wandering is a condition that is often seen in nursing homes where people with dementia are being looked after. This is where people may seem to wander around the nursing home. They can sometimes pause, perhaps stop and look out of the window. And it is, again, was thought to be part of the dementia. It is part of the dementia, but it may actually be helped by anti-seizure medications. And amnestic wandering is episodic, suggesting that that may be actually ictal in origin. If you have Alzheimer's disease and epilepsy, you present with your cognitive decline earlier. If you have Alzheimer's disease and subclinical epileptiform activity, you present with your cognitive decline earlier. More than that, if you have mild cognitive impairment, which is the harbinger of Alzheimer's disease, and you have seizures, you can present nearly 7 years earlier with the cognitive difficulties than if you don't have seizures. So there is something more going on that is linking these conditions. We can look at animal models and suggest that seizures actually contribute to pathogenesis. So this is a transgenic model of dementia, transgenic model of Alzheimer's disease with the pre-signaling-1, that's the PS1 mutation. And you can see in the transgenic mouse, there is evidence of neuronal loss compared to the normal mouse, the control. But if you have seizures in the pre-signaling-1 transgenic mouse, then there is almost obliteration of the nerve cells, as is illustrated in the panels towards the right of the slide. Animal models of Alzheimer's disease can also show ictal activity as an upstream mechanism contributing to cognitive deficits. High levels of beta amyloid also seem to associate with epileptiform activity. And if we look at it the other way around, reducing tau in an animal model of Dravet syndrome, so severe epilepsy, a model of severe epilepsy in childhood, if you reduce tau, tau being an important protein in Alzheimer's disease, that reduces the frequency of seizures. Now, don't expect anyone to remember this slide in any detail. You will not be tested on this later, but CDK5 was a molecule that was very important to me when I was doing my PhD. It's a molecule that's been shown to be important in causing hyperphosphorylation, an excessive and abnormal phosphorylation of the protein tau, that protein that can be important in Alzheimer's disease. And what happens is that there is misregulation or deregulation of CDK5, and that then causes the hyperphosphorylation as illustrated here. What we showed is that you can also have deregulation of CDK5 associated with epileptogenic pathologies. So this is the NMDA receptor opening, calcium comes in, as can happen in seizures, that triggers activation of calpain and then deregulation of CDK5. And you can set up a cycle whereby excitotoxic cell loss may contribute to tau hyperphosphorylation. Does this actually play out in real life? So this is quite a dramatic slide of someone who did have very refractory epilepsy. As you can see, they underwent a temporal lobectomy. So the temporal lobe is removed on the right-hand side. This was done many years ago, but the woman continued to have seizures. And although at that time, imaging didn't identify any other cause for the seizures, when it came to post-mortem, it was found that there was an area of cortical dysplasia, as is illustrated in the box there, and that was probably contributing to the ongoing seizures that happened after the temporal lobectomy. What we then did is look at that for tau, this molecule that is important in Alzheimer's disease. And what we found is that you can see abnormal phosphorylation of tau only within the region of cortical dysplasia. not in the adjacent cortex at all. So the adjacent cortex has been exposed to the same medication, same life experiences, same vascular risk as the rest of the cortex, as the cortex where there is cortical dysplasia, but you only see the tau hyperphosphorylation in the region of cortical dysplasia. What does this tell us? Well, we're showing now the bringing together of a pathology that happened very early in life, cortical dysplasia, with a neurodegenerative pathology of Alzheimer's disease, and suggesting that the epileptogenic cortex is the part of the brain that is really prone to tau-mediated neurodegeneration. Is there neurodegeneration? Well, we can look at cell counts, and you can show that in the abnormal cortex, there is tau hyperphosphorylation, these are the brown stains here, and there is also neuronal loss compared to the adjacent normal cortex. You can also look and show that there are tau tangles within the abnormal neurons within the area of cortical dysplasia. This is shown with silver staining and then also shown by confocal microscopy. So there does seem to be a very close intersection between epilepsy and dementia. And epilepsy likely, the seizures are likely contributing to the pathogenesis of the dementia. Dementia is also then associated with epilepsy. And epilepsy in older people is complicated. There are lots and lots of things going on. In particular, we have to be very mindful of comorbidity, and we'll come on to that a little bit more when we talk about treatment options. But thinking about the underlying etiology and how these conditions might contribute to the seizures that we see in older people is critical. It's impossible for anyone from Oxford to give a talk on epilepsy without somehow mentioning autoantibodies. And so autoimmunity and pathogenesis of epilepsy in older people, well, it contributes. It's a part of the process, and it can certainly contribute to acute seizures. We see that often with the autoimmune encephalitides, and certain antibodies are more common as we get older, as is illustrated here. The overall rate of developing epilepsy outside of all of the acute illness, though, is relatively low. So that brings us to a second poll. Well, if we've now done autoimmunity, well, what is the other major frontier in epilepsy and older people? So I'd just like to open the poll up after I've read through the options. So the other major frontier in epilepsy in older people, what we'd like you to suggest is that tumor-related epilepsy? Is it epilepsy comorbidities? Is it novel treatments? Is it novel diagnostics? Is it something else? Or actually, is there no new frontier? We'll just open up the poll now. So in terms of the results, so tumor-related epilepsy was 17%. Epilepsy comorbidity was very important, so 50% of people put that. Novel treatments, 17%. Novel diagnostics, 9%. Something else, 4%. And there is no new frontier, 4%. So there's going to be a new frontier, though. And there may well be something else. So if we look at that, if we go back to our slide on etiologies of epilepsy in the elderly, we've talked about the pathophysiology of how strokes can cause acute and late onset seizures. We've talked about Alzheimer's disease. We haven't mentioned too much about tumor-related epilepsy, but that does contribute to about 13% of epilepsy in older people. Other dementias, less common, and then other causes, and we alluded to the autoimmune causes of seizures at least, and in some cases, epilepsy. But I would propose that actually the frontier is something else, because what this slide shows is etiologies of epilepsy in older people who develop epilepsy in later life. And now, fortunately, we're in the position where many more people who had epilepsy in early life are actually living into old age. And we should be very thankful for all of the advances across medicine that have enabled that. We're also doing far more work in terms of the genomics of understanding those early onset epilepsies. But one of the things that I think we're less familiar with at the moment and understand less well is what happens to these early onset genetic epilepsies as people get older. What happens in terms of systemic comorbidities, as well as neurodevelopmental comorbidities, risks to cognitive decline, and so on and so forth. So I think that at least is going to be one new frontier over the next 5 to 10 years or so. So in conclusion, epilepsy in older people is a burgeoning health problem. We've talked and shown here the data from high-income settings, but also remember the slide showing from the Global Burden of Disease Survey that the prevalence of epilepsy is also increasing worldwide. Populations are aging 3 times more quickly in low to middle income countries than in high income settings. And the incidence of epilepsy is therefore going to rise worldwide in older people, particularly going forwards. There are multiple potential etiologies. We can't cover it all, but we've talked a little bit about the pathogenesis of how stroke can cause early seizures or remote epilepsy. We contend that there is a very clear intersection between epilepsy and dementia, but we really need to work on that and try and better understand and disentangle epilepsy, dementia, and stroke, because if we can understand how those 3 conditions intersect, we can potentially make meaningful difference at scale. It also suggests that the study of people with complex early onset epilepsy who progress into adulthood is essential. And we would all be encouraged to really look at epilepsy in older people, because even Captain America will get old one day. Thank you so much for your attention.
Thank you very much, Arjune, for that fantastic overview. I think for the sake of time, we will proceed straight to the next talk, but if we can have questions put into the question and answer, and I know there's a couple already for the next one. Eugen, are we going with you next or Taoufik next?
I'm ready to go. I don't see Taoufik at the moment. If
he's here, I think. Yeah.
Okay, great.
Oh no. Yeah. Taoufik, are you able to do the next one? You may be still on mute. No, we can't hear you. So maybe to Eugen, then we will go with you for this and hope that we can get Taoufik on for the last talk. So Professor Eugen Trinka is Professor and Head of Department at Passless University Hospital in Salzburg in Austria, and has a lot of experience, particularly with regard to treatment, and that's what he's going to talk about today. So thank you, Eugen.
So thank you very much, Helen, for the introduction, and dear friends, dear colleagues. I'm going to talk about treatment, but I will also refer to some things which you heard before from Arjune, because it's a lot about comorbidity, interaction, and causes of epilepsy in the elderly. So these are my disclosures, which you saw already. I will start also with the case vignette and tell you about the current treatment options with anti-seizure medicines and focus on the choices based on the comorbidities. So what are we going to talk about? And I'm sure you know that at a certain age, things change with Captain America, but also with Otto Eduard Leopold von Bismarck, because he introduced the border, which is usually set at 65 years of age. Some studies include also 60 years plus and call it elderly. And then there is also a category where you have young olds, old olds, and very old olds, which is very arbitrary. And he introduced the 65 years old because of retirement. And he paid all the German people retirement money, which he could afford because not many people reached this age. So most of them died previously. So this is why we have 65. It's not related to biology. Biology is what Abraham Lincoln said. It depends on the attitude, on the general health, and the state of mind. And some people can have a state of mind of a very old person already at 50. And examples of dementia starting earlier than the cutoff rate at 65 is important. So, and in the end, it's not the years in your life that count, it's the life in your years that count. And that's what Abraham Lincoln said. And I start with a case description. Dr. Diaz, at night, his wife woke up and thought that there is an earthquake. She saw her husband lying next to her, head flexed backwards, foam and blood coming out of his mouth. His arms were flexed and shaking, the legs were extended. And after a few minutes, he stopped shaking and fell in deep sleep again with no reactivity. She turned him to the side, secured open airways, and called the emergency doctor, and the patient was brought to our hospital with the helicopter. And that's a wonderful wife. She did all the right things, what you have to do in a patient who is in deep coma after a seizure. And on admission, he improved. He gradually awoke. He was slightly confused, disoriented. He had amnesia for the event. His examination was normal, ECG normal, the lab was normal. Mild atrophy in the CT, some small and old vascular lesions. Past medical history was uneventful. At age 72, no pre-medication, family history negative. But when you explore deeper, he said that he had some episodes, 1 to 2 minutes of a strange taste, unexplainable, but incomparable for the patient, with arrest of activities, but retained comprehension. And he could also remember these episodes, but he was not able to act in that way. So that was one of the indications why we did, of course, an EEG quite early and prolonged. And we found this activity starting from the left temporal lobe with rhythmic theta waves expanding over the left temporal region, evolving to one of his habitual seizures with this strange strange taste. This was his MRI, and you already saw an MRI, and these white spots in the FLAIR images, which you see here, are vascular lesions, and he had one in the or more in the right hemisphere involving the cortex, but he had also some in the left hemisphere. So if you look at the DWA, you see that the ones in the right hemisphere are the new ones. These are embolic cortical strokes, which you have here in the frontal lobe and in the parietal lobe, both probably the middle cerebral artery. So this patient had two things. First of all, he had an acute seizure caused by a stroke, and he had seizures heralding the stroke. And if you remember, the new seizures were in the right hemisphere, the ictal EEG with his strange taste, with his gustatory seizure, was in the left hemisphere. So what you need to do in acute symptomatic seizures due to a stroke, you need, of course, the full technical diagnostic and the appropriate treatment, thrombolysis, if appropriate, etc. But also any seizure in the elderly population, let's say 60 years plus, needs a full cerebrovascular investigation, including all the risk factors, including neurosonology and etc., in order to prevent a stroke, because seizures in the elderly are heralding strokes in many cases. So this patient obviously had both symptomatic and also remote, acute symptomatic and also remote symptomatic seizures. When we look at the acute symptomatic seizures, the relapse risk of having a late seizure, an unprovoked or a remote symptomatic seizure, is not equally distributed among the different etiologies. If you look at stroke, there's a considerable risk of having seizures. And you also heard about the risk stratification through the SELECT score, which was presented in the previous talk, which you heard. When there are certain factors, you can expect that this patient has seizures in up to 70 or 80% within 2 years, within 2 years. And if you think about the epilepsy definition, which is 60% relapse risk, it's even higher. The problem here is we cannot prevent a remote or a late post-stroke seizure with any medication. There are no studies showing that. There are currently studies on the way, and we have conducted one of them where you will hear the results, I would say, in a few weeks' time for the first time. But at the time being, we cannot prevent epilepsy, even if we know that the risk is high. What complicates treatment of seizures in the elderly? It's the increased sensitivity and the increased susceptibility to the consequence of a seizure. Many of the patients have oral anticoagulants. They have ordered pharmacokinetics and pharmacodynamics, explaining the increased sensitivity to CNS active drugs, also leading to a higher frequency of secondary injuries, for instance, through falls and coordination problems. Associated medical disorders are key. Renal insufficiency. You heard about dementia, and there's a reciprocal relationship, including dementia and depression and sleep disturbances, which can cause problems. Polytherapy is the rule and not the exception. There are a few factors which are, to my opinion, very important. One factor is the cognitive impairment before the onset of epilepsy. This comes from a randomized controlled trial, which we did in Germany, Austria, and Switzerland, where almost 60% of the patients had cognitive complaints, mild cognitive impairment or marked cognitive impairment assessed by the EpiTrack. And these patients were 60 years plus. And the seizure can be regarded as one sign of cognitive problems or degeneration of the brain. So there is a true importance to assess the cognition. The second point is from a population-based study, which we did in Denmark, Ireland, Austria, and Romania. We looked at the comorbidities, and in a latent class analysis, we found 3 clusters. What was specifically important is that patients with focal and with bilateral tonic-clonic seizures, higher age, and comorbidities, such as stroke, respiratory and pulmonary disease, and cardiovascular disease, had a higher risk of experiencing affective disorders. So the somatic comorbidity clusters together with the psychiatric comorbidity, supporting the view that the strict dissection between soma and psyche does no longer hold true. A few minutes to talk about the evidence-based treatment. There are only 4 randomized controlled trials in treatment of the elderly, starting in the year 1999. Lamotrigine against controlled release, immediate release carbamazepine. Then there was a 3-arm study by Rowan, the VA study, which was class 1. The lamotrigine study was redone with controlled release carbamazepine with different results. And then we had a class 1 study looking at levetiracetam, lamotrigine, and controlled release carbamazepine. And the last study, Pullman-Eden, is one sub-analysis of the COMET trial comparing levetiracetam to conventional or older anti-seizure medicines. I already mentioned the first study, 1999, comparing 150 patients aged 65 plus, where they received newly onset epilepsy, lamotrigine, or immediate release carbamazepine, up to 1,000 milligrams, 4 weeks titration. And there was no difference in terms of seizure freedom, you see on the right side, but there was a significant difference on the number of patients who remained in the study due to the better tolerability of lamotrigine as compared to immediate release carbamazepine. Immediate release carbamazepine was also used in this study, comparing gabapentin and lamotrigine against immediate release. And what you see is that lamotrigine was significantly better than carbamazepine, and gabapentin was also significantly better than carbamazepine in terms of retention rate over 1 year. What I have to say is that immediate release carbamazepine is worse tolerated than controlled release carbamazepine, which was used here. So the Brody study comparing against lamotrigine in newly diagnosed epilepsy in the elderly was reproduced simply using another comparator, controlled release. And what you see, there is no significant difference between those two drugs in this study. And also the serum levels, which were analyzed in both studies, they were much higher in the immediate release group than in the controlled release, supporting the clinical utility of having slow release substances. Exactly this was tested, controlled release carbamazepine against lamotrigine and levetiracetam in the STEP 1 trial by Konrad Verhan as first author. And what came out here, it was levetiracetam for the first time significantly better than controlled release carbamazepine. So I think that was one of the breakthroughs, that you have one substance which was significantly better in terms of retention rate, and this was designed as superiority trial against carbamazepine. A sub-analysis from the COMET trial, and just look at the graphs on the right side. Over 1 year, levetiracetam was better than valproic acid controlled release, and it was better than carbamazepine controlled release, significant. Again, supportive evidence that levetiracetam is better tolerated than controlled release carbamazepine. When you look at what happens in the real world, and this comes from North Germany, lamotrigine and levetiracetam and valproic acid are the 3 most commonly prescribed drugs over the past years. So we know that we can do meta-analysis, and this is one for looking at post-stroke seizures. They found no difference between levetiracetam and lamotrigine in the treatment of post-stroke seizures, but the adverse event were higher with levetiracetam versus lamotrigine. So again, the difference is in the tolerability. One of the reasons is that levetiracetam tends to be overdosed. Just look at the clearance of levetiracetam. At the age of 35 plus, the clearance goes down dramatically, reaching about 50% of the clearance of an adult person of levetiracetam. So you have to halve the dose in order to get the same serum level. And this has not been done in the studies which were used there. So we tend to overdose these drugs. One of the consequences is, of course, side effect rate, which is influenced by that. Falls in the elderly are one of the major problems, and they are multifactorial. They can be caused by overdosing CNS active drugs, as I said previously, visual impairment, postural hypotension, but also degenerative joint disease, stroke, movement disorders, etc. There are multiple factors, including postural hypotension. So if we look at the other aspect of the drug, the anti-seizure medicine-related drug, we can divide to enzyme inducers and non-enzyme inducers. They are most often enzyme inhibitors, or they are neutral, as you see here. There are classic anti-seizure medicines which are broad-spectrum enzyme inducers, and they have consequences in the elderly. And one of the chronic effects of enzyme-inducing anti-seizure medicines is interactions, number one, effect on gonadal steroids, effect on vitamin D and osteoporosis, and they influence the lipid profile and thereby the cardiovascular and cerebrovascular risk factors. When we look at the osteoporosis, it doesn't seem to be that clear. There's a recent study which came out this summer by Colin Josephson looking at the independent association of incident epilepsy and enzyme-inducing and non-enzyme-inducing anti-seizure medicines. And what you see here clearly is that both medications, enzyme inducers and non-enzyme inducers, increase the risk for osteoporosis, both. So it's not only the enzyme inducers, but also epilepsy itself or anti-seizure medicine itself having an influence on the risk of osteoporosis. It's much clearer when we look at vascular risk factors with enzyme inducers. Carbamazepine, phenytoin, they increase the vascular risk factors, cholesterol, high sensitivity CRP, and homocysteine dramatically with enzyme-inducing effects. But also here, valproic acid has an influence, as a small influence also with lamotrigine. In the randomized controlled trial, which I showed you previously, the step 1 trial, the lipid measurements were included. And there were interesting results which were seen with carbamazepine in the triglycerides, especially in male individuals, but not in women. So there's a gender-specific effect of carbamazepine in patients with epilepsy with carbamazepine. What you see in addition to that is that there is a loss of the effect of lipid-lowering agents. So the key message is that the native effect on lipids were inconsistent and subject to drug-gender interaction, carbamazepine and triglycerides. And the other effect is that carbamazepine interferes with the ability of statins via the CYP3A4 mechanisms. This is also coming out from a randomized controlled trial where total cholesterol was significantly increased to baseline when patients were randomized on controlled release carbamazepine, and they were not increased when they received in this monotherapy licensing trial aceclidine acetate, which does not have a strong enzyme-inducing action. So again, increase of total cholesterol, increase of LDL cholesterol due to carbamazepine, strong enzyme-inducing action is not found with aceclidine acetate. But there may be other interactions. As you see here, rosuvastatin is decreased in the absorption when you have a co-medication of aceclidine acetate. So one thing is clear, it does not increase cholesterol, but when you have an elevated cholesterol and a patient is on rosuvastatin, the add-on of aceclidine acetate will reduce the absorption and minimize the effect of rosuvastatin by 36 to 39%. Interactions are of key importance when it comes to non-vitamin K antagonists, but also vitamin K. But there has been a strong recommendation that direct oral anticoagulants like dabigatran, apixaban, edoxaban, and rivaroxaban interact with levetiracetam strongly, leading to a reduced efficacy of the oral anticoagulation. And the European Heart Rhythm Association said that the levetiracetam is contraindicated when you take one of the new oral anticoagulants. In their revised edition, which came out in 2021, they have been much more modest and said that there should be cautiously used levetiracetam, which you see here shaded in bright blue, and they're only the dark blue ones are contraindicated. But what is clear is that At the moment, we can draw a firm conclusion regarding levetiracetam. We should use it with caution and measure the serum levels of the oral anticoagulant. On the other side, brivaracetam, lacosamide, and lamotrigine don't have interactions with these medications. So when starting in a patient with direct oral anticoagulants, it should be taken into consideration not to use enzyme inducers and not to use levetiracetam. In this context, choose one of these medications which you see here. So overall, when you simply look at the evidence of efficacy, there is gabapentin and lamotrigine in the original report, which is 10 years old. Additions, new studies show that levetiracetam is similarly effective and well tolerated, similar to lamotrigine, and superior to immediate release and also to controlled release carbamazepine. Good safety data came up with topiramate, zonisamide, perampanel, islicarbazepine, acetate, lacosamide, but also brivaracetam. So what I conclude here is that the first-line anti-seizure medicines are lamotrigine and gabapentin according to the evidence-based review. Since we have newer studies which were not included there, levetiracetam should be included as a treatment of choice in the elderly. When it comes to interaction, levetiracetam does not have interaction with most of the drugs. Maybe it has interaction with new oral or direct oral anticoagulants. So therefore, other drugs such as lacosamide or brivaracetam or gabapentin or lamotrigine are useful in the elderly. Interactions are also important when it comes to therapeutic, chemotherapeutic drugs in tumors and to antibiotics, which I did not cover at this talk. There's increased pharmacodynamic sensitivity, which may lead to poorer tolerability, and you need a low dose in the elderly, generally half of the dose which you have in a normal adult. And there is increasing class 4 data on safety and tolerability with lacosamide, topiramate, zonisamide, islicarbazepine, perampanel, and also brivaracetam. And I thank you for your attention.
Thank you, Eugen, for that great overview. Just to remind everybody that you can put questions in the Q&A at the bottom of the screen, and we'll be taking questions shortly. Unfortunately, Dr. Alsaadi has not been able to join, and therefore I will present his slides. Just to highlight that Taoufik Alsaadi is head of neurology at the American Center for Psychiatry and Neurology in the UAE, and is also our current chair of the ILAE Commission for Epilepsy in the Elderly. So if you could share the slides, great, thank you. Okay, so over the course of this talk, the main objectives are to review the epidemiological data in older people with epilepsy, to review etiological and risk factors, and to understand the unique characteristics of seizures in this population. But the key problem we have to start with, and perhaps what we wanted to address in part at the beginning of this, is what do we define as the elderly? Namely, who are the older people with epilepsy and what age do we start this from with regard to discussion? According to the World Health Organization, aging is commonly measured by chronological age. And as a convention, a person over the age of 65 is often referred to as elderly. But unhealthy aging, however, is defined as developing and maintaining the functional ability that enables well-being in the older age. But there's no real clear definition. it's common, particularly in developed nations or resource-rich nations, to define elderly as those over 60 or 65. And one classification has been proposed that divides the elderly into three groups: the young old, middle old, and the oldest old. The young old being 65 to 74, the middle age of the elderly being 75 to 84, and the oldest old, older than 85 years. And if we look at incidence of epilepsy, as we've already heard in part from the previous two speakers, it's the incidence of epilepsy in the older population is increasing rapidly. And a further increase is in incidence and prevalence is expected in age and societies as people get older. The population in this age group is increasing, and therefore, of course, prevalence of epilepsy in this population will increase. The incidence of seizures in the elderly is higher when compared with younger populations for the variety of pathophysiologies, underlying etiologies that has already been discussed. And in patients over the age of 75, it increases by up to 2 to 3-fold. In an Icelandic cohort that we'll look at in more detail, the incidence of epilepsy was 70.5 per 100,000 person years in patients 65 to 74, 168.5 per 100,000 person years for patients 75 to 84, and 151.9 per 100,000 person years for patients over 85. So actually there's a doubling of incidence even between 65 and 85. And similar rates were seen for patients 60 years and older from the original Rochester studies. The other point about this, however, is that the overall mortality risk for elderly with epilepsy is about 2 to 3 times that of the general elderly population. And of course, there is an issue about, you could argue, are most of the seizures that we see in the elderly acute symptomatic as opposed to unprovoked seizures, or what we would call a definition of epilepsy. You can see from these two studies that the curve with regard to incidence for both acute symptomatic and unprovoked seizures is similar, and particularly as we go into the elderly population. This just overviews the incidence of acute symptomatic seizures, not the diagnosis of unprovoked seizures, which would be epilepsy. And this is from the original, this is from, I think, the Minnesota study published in '95. And you can see there's a gradual increase with age of the incidence of acute symptomatic seizures. And in this study, a range of different underlying causes, head trauma and cerebral vascular disease and infection being that was most prevalent, but also another range, including eclampsia and encephalopathy being causes. And again, here, this is data from predominantly the Icelandic study, which was more recent, but that's showing, again, an increase with age of acute symptomatic seizures, but the sense that this incidence is increasing. You can see the curves with regard to age, both for epilepsy and and all unprovoked seizures, really going up in the later phases of life. Not quite the same seen in the single unprovoked seizures. But actually, if you look at the bottom right, looking at comparative studies, you can see that they all show the similar rise in incidence in the older population. And this just gives an indication of trends over time. Our general impression that with an increasing population in the elderly, we're going to see higher incidence. And this has been borne out through this study, longitudinal study in Finland, showing the overall incidence, but the dotted line showing the trend with the increase over recent years. But there are different aspects of seizures that are actually different in characteristics compared to a younger population. And that may range from not only the incidence, as we've seen, the underlying cause, as we've already had discussed, but also clinical manifestations treatment and anti-seizure medication pharmacokinetics, again, as we've seen, as well as side effects and indeed overall prognosis. With regard to clinical manifestations, this slide summarizes the differences that we see. Warnings to the seizures are less frequent or maybe very non-specific. Automatisms in, for example, temporal lobe onset seizures, much less frequent. They may present with different difficulties in differential diagnosis, not least with altered mental status, confusion, or memory disturbance that may not necessarily be recognized as seizures. The EEG, unhelpfully, may not show typical epileptiform patterns, and postictal confusion may be quite prolonged. And just to emphasize on this, although patients frequently may present with mesial temporal symptoms, such symptoms may also must be masqueraded as discrete confusion or wandering episodes, which are often mistaken as fluctuations in maybe as part of the overall dementia state or indeed sundowning. The incidence of status epilepticus increases after the age of 60. It's often of longer duration than we might see in the younger population, but it certainly has markedly increased morbidity. And also dependent on the existing comorbidities, the mortality rate for status epilepticus in the elderly may be as high as 50%. And further to that, non-convulsive status epilepticus may be initially recognized, resulting in treatment delays. And of course, the impact of seizures with migrator, we've heard about this already from the previous two speakers, not least, drop attacks, falls, but there might be the unpleasant experience of the actual seizure. Postictal states may be prolonged. Postictal hemiplegia may lead to a misdiagnosis of a stroke. Serious injuries are more likely because of the risk of fractures, and the impact on the social life of the patient and others, family members, friends, and carers may be quite high, especially as there's a degree of higher dependency. But that said, seizures may be easier to control with anti-seizure medications. But that said also, as has previously been discussed, the elderly may be more prone to side effects. There may be age-related adverse events in the elderly with regard to treatment, predominantly because of their change in metabolism, when we have to remember that the drug-drug interactions, they're more likely in the older population to be on other medications, and we have to be aware of the interactions with anti-seizure medications. Semiology may also be perplexing. Just to highlight this here, you can see here on the right, focal seizures are most common, and even then, those that are labeled generalized tonic-clonic may be focal, evolving to bilateral tonic-clonic. And as I've already commented, auras may be rare or very non-specific. Automatism is quite rare, and there may be prolonged postictal confusion. So just to ask you a final question here, what is the most common cause of new onset seizures in the older people with epilepsy? Traumatic brain injury, dementia, cerebral vascular accidents, stroke, tumors, or none of the above? Well, it seems here equally you've put cerebral vascular accident and stroke. You could argue, a great deal of similarity, and that's likely to be correct. Here, just highlights from one study, possible risk factors for epilepsy in the elderly, and certainly the odds ratio is highest for cerebrovascular diseases, but actually cerebrovascular disorders with dementia actually gives the highest, showing a greater predisposition. And here, such things as being on coexistent treatment with statins, or indeed necessarily, but is more likely, I think if it's on the statins, but certainly greater than 85 versus 66 to 74. Obviously, the older you are, the greater the risk factor. And this just highlights the various risk factors associated with new onset epilepsy over the age of 50. The most common risk factors being stroke and indeed neoplasm and dementia. Chronic alcoholism was the most common metabolic risk factor, which accounted for 84% of the cases of metabolic disease being a cause, and this being significantly more frequent in males. But there was no identifiable epilepsy risk factor in 41% of the patients in total. And here, a study from Eugen's group looking at the causes of epilepsy over 60 years of age. And at this time, cryptogenic was the largest group, although you'd say that was unknown cause, probably a little less now, but certainly here, vascular giving the greatest cause of that was known. And here from the veterans cooperative study, the primary etiology, again, cerebral infarct or cerebral vascular disease being the most common, with unknown being the second. So just to summarize, the causes of seizure in older people with epilepsy, cardiovascular disease, cerebrovascular disease being the most common, primary degenerative disorders and trauma and brain tumors being next. Brain tumors, we've already heard about. The most common cause of epilepsy in the elderly is second only to cerebrovascular disease. Nearly 10 to 30% of all cases with older people's epilepsy, with seizures being the onset symptom in 20 to 40% of patients with brain tumor, and 20 to 45% of patients presenting with epileptic seizures during the course of the disease. Epileptic seizures caused by brain tumors, of course, may have an influence on increasing the mortality in the elderly. And finally, there's also the consideration of comorbid disease, not only with regard to comorbid neurological disease, whether that be the fact that epilepsy is the result of certain neurological diseases, but of course there is also the issue of other organ disease, which is going to influence how we may proceed with treatment, and particularly with how individuals maybe react, have adverse events, or indeed metabolize treatment. So in conclusion, certainly we're going to be working over the next, during this term, on trying to reach a consensus on how to best define epilepsy in this population, and particularly looking perhaps at a definition about what we mean. Incidence data are scarcer than prevalence data and are missing for large areas of the world. Of course, most of the studies have been conducted in resource-rich environments, and what is happening in resource-poor environments, where, of course, 80% of those with epilepsy indeed reside. Epilepsy in the elderly have distinct characteristics in semiology, and several etiological factors have been identified to cause seizures in this population. Comorbidities are common, whether this is neurological or other, and affects the selection of anti-seizure medications. So on that note, if we stop sharing, we can perhaps ask the panelists to open their videos and unmute themselves. We could proceed to perhaps some of the questions that have been asked. Okay, so two questions, actually, one for each of you probably. For the elderly patients on tube feeding, does the syrup form of the anti-seizure medicine affect the bioavailability?
Most of the drugs which are available as syrup have the same bioavailability as when the patient swallow. as a matter of fact, there are few studies looking on crushing the tablets and giving it via the tube. Then there might be some absorption difficulties. But the main variability of absorption is when there is gastrointestinal problems and comorbidities where the patients really don't get the drug in. And for these older, elderly, frail people, a subcutaneous application of the drugs, for instance, in the nursery homes, are a viable option.
Thank you. And a question perhaps for you in the first instance, Arjune. I mean, have you seen that levetiracetam may worsen psychiatric symptoms in patients with dementia?
Thank you, and thank you for the question. So, I mean, levetiracetam does have a neuropsychiatric profile, adverse neuropsychiatric effects. You would perhaps be cautious if there was a very strong psychiatric history pre-existing to go for levetiracetam as first line, especially as you've heard, there are options including lamotrigine, we use a lot, lacosamide as well. With the older population, again, as Professor Trinka mentioned, starting at a very low dose and titrating to a relatively low dose, making sure that you don't cross the threshold where because the creatinine clearance is lower and you get side effects for that reason can help. So we have quite a lot of people who do very well with levetiracetam 250 milligrams twice a day and don't experience those neuropsychiatric side effects at that low dose.
If I may follow that, what you said now, Professor Sen, Arjune, my experience is also the same as you said, that the psychiatric adverse events are more common in the younger population, and the elderly tend to be more sedated than they are activated or aggressive. I don't know. There are no good studies about that, but that's something I quite often observe, sedation.
Thank you. A question I had, and also someone else has got, I presume that subclinical seizures are underdiagnosed in particularly the dementia population, and therefore what threshold do you have to investigate or indeed treat if there haven't been clinical seizures?
Shall I answer that? So it's a great question, and I think that we need far more data on this. So if you do prolonged recording in people with dementia, you are very likely to, well, not very likely, but you may well pick up electrographic seizures. And some of those studies have actually picked up clinical seizures that were just not recognized as clinical seizures. So in that case, you would treat. I think that it's uncertain yet whether treating subclinical epileptiform activity in dementia actually will help cognition, because that's what you would be looking to do, stabilize the nerve cell network and see if you can offer benefit to cognition. And there are studies, we've done a study, there's been a study from California looking at anti-seizure medications to see whether that's effective or not. But it's a very good question and something that we need more data on.
Thank you.
And it was, you used levetiracetam, correct?
Yeah, so I don't want to be self-promoting on the ILAE webinar.
This is why I asked you.
So in our study, and also in the study by Keith Fossil's group, we used levetiracetam. One of the key differences is that we excluded people who had epileptiform discharges on their EEG. So it was really, we were looking to see if levetiracetam associated with an improvement in cognition in people with dementia. And Keith Fossil's study showed that if you did have epileptiform discharges on your EEG, then there was an improvement in executive function in people with dementia. These are both small studies that really require broader replication.
Thank you. There's a question here about the use of gabapentin in monotherapy regarding adverse events and efficacy, and what your personal experience in it, regardless of the evidence base.
First of all, it works, but there are several problems. Problem number one is gabapentin is mainly eliminated, 100% eliminated via renal excretion. And as I showed, the renal clearance decreases significantly with age. So you need lower doses, much lower doses, in order to get the result. Problem number two, gabapentin has also sedative effects in the elderly if it's dosed too high. And number three, this is something where I cannot give you data because the data say that it works. The efficacy seems, to my personal judgment and opinion, very subjectively lower than with other anti-seizure medicines. And the tolerability is not as good as with lamotrigine and levetiracetam. So this is why I don't use it. Now, previously I was very friendly for that. What is an option for those when you have problems with interaction is lacosamide and brivaracetam. They're quite good data and they're well tolerated. Perampanel has some problems, but it's also a highly effective drug. So this is related to the newer drugs.
Okay, thank you. There's a question about etiology. And have you seen stroke located in deeper regions such as the basal ganglia or thalamus associated with epilepsy in this population?
So thank you. So you wouldn't expect that lacuna strokes off themselves would cause seizures because epilepsy is a cortical disorder. But it's a very good question because the lacuna stroke might be suggestive of broader vascular risk, so broader cerebrovascular risk. And so you would want to treat vascular risk factors and get on top of that if you had a scan that showed a lacuna stroke, but more that way round rather than the lacuna stroke causing the seizures.
That's our experience in children as well. Okay. There is a question about the use of lamotrigine. And in view of the fact, well, there's two questions really. There's a question that if levetiracetam isn't tolerated, and they're on the anticoagulants, what would be the drug of choice? And I sort of sit here because, lamotrigine may be helpful, but there is a concern that actually it needs a slow titration. And what about the risk of new seizures and fractures in that titration period?
Yeah, I think this is a very important question because despite the fact that lamotrigine has excellent data in the clinical studies, so the clinical practice, I personally, working in a hospital, the very slow titration is a problem with lamotrigine. So what we do is use lacosamide or brivaracetam and to get a much earlier result in order to keep the patient safe. And I think the question was a very good one because you want to avoid all the other secondary complications. So IV loading is something which you can do, and you get a serum level which is effective.
Can I mention something on that, Eugen, quickly as well? So and thanks, Helen. So thanks for the question. So less so in older populations, but if you're using lamotrigine and you want control quickly, what we do sometimes do is bridge with clobazam. So you can get control very quickly with clobazam to allow the lamotrigine to up-titrate because you know that the data from SANAD-2 and so on and so forth shows better long-term tolerability and retention with lamotrigine. Caveat in the older people is benzodiazepines can be very sedating. So you might use clobazam 5 milligrams twice a day or very low dose if you wanted that kind of bridge.
Yeah.
Thank you. And another question, should neurologists be assessing cardiovascular health in first seizure epilepsy clinics as routine in older patients?
Definitely.
Yes.
Definitely. So so this should really be done, but it isn't, and I think that's why the question has arisen. It's very good to highlight that, and we should all be highlighting that. In particular, what you can do is check the blood pressure. Every clinic room should really have the blood pressure, even if you don't have, a method of checking a glucose or anything like that, but you can check the blood pressure in clinic. So everyone over the age of 50 presenting with a possible seizure should really have their blood pressure checked.
Okay. Yeah. The final question, because of time, what do you think about the influence of insomnia and sleep apnea on inducing epilepsy of older people?
You go first, then Eugen.
Okay. So there is an association of sleep apnea and seizures. So if you have, for instance, seizure in the elderly and a sleep apnea, you treat the sleep apnea, the seizures are getting better. That's number two. That's number one. Number two is that the sleep apnea in the elderly is often associated with multiple cerebrovascular risk factors. So you have to treat that. And that's also for prevention of worsening of epilepsy. The question whether insomnia per se is a factor which you can treat in the elderly in order to improve epilepsy is open, because many of them do not respond to melatonin. Sedation with or sleeping pills with barbiturates are of course out. With benzodiazepines have a sedative effect, increasing the force. Some of them are tolerable, but there are other problems with that. So when it comes to sleep apnea, that should be treated. When it comes to insomnia, other factors should be ruled out, and sleep hygiene should be number one. My personal.
Yeah, I mean, I would echo that completely. I mean, we increasingly recognize that sleep apnea is a potential risk factor for vascular disease, and treating sleep apnea, if you suspect that can improve seizures. And because I'm conscious of time, I'll end with a brief case about the insomnia angle. So we had a patient who was nearly 78, and she presented with a clear-cut convulsive seizure and then had a convulsion in the accident and emergency department. And when we did the EEG, she actually had generalized spike wave discharge on her EEG. And the reason she had become sleep deprived is her husband had prostatism and he had had multiple strokes. And so she had become sleep deprived for the first time at the age of, in her late 70s, because of the impact of her husband's illnesses. So we really need to always think about things holistically, especially in older populations.
Absolutely. It takes full circle to think about things holistically in the older population. So on that note, I think it's time for me to draw this to a close. I'd like to thank profusely Professor Eugen Trinka, Arjune Sen, and also Taoufik Alsaadi, who's been here, but due to technical problems was not able to join, and for all the work that he has put into this and elsewhere. As you leave, you will be asked to complete a short survey that will pop up when you leave the e-forum. Tomorrow you will receive an email with details on how to access the virtual case to consolidate your learnings. Please keep an eye on the ILAE social media pages about other educational events, but including our next e-forum, which will be on optimizing models of care during transition from childhood to adulthood. But this e-forum will be available on demand from tomorrow. So on that note, thank you so much and have a good rest of the day, evening, wherever you may be. Thank you very much.